Good morning, everyone. This is Annalise Garrison. Welcome back to my channel. And today I'm going to upload another video. It's already on the channel, but it's 7 years old, so I needed to update it. It's still relevant. That's why I'm keeping the video. But I just want you to know that when I tutor, each one of my topics has its own concepts. Like infection control will have its own concepts. Prioritization will have its own concepts. Triage, legal and leadership, EKGs, pharmacology, all these sections will now have their own concepts, okay? The other thing I did was the tutoring is no longer $30 an hour. It works out to be $50 a topic. Now, some topics take longer than others. Prioritization, for example, takes longer than infection control. So you're not paying per hour. I mean, you kind of are, but now you're paying per topic, okay? So those are the two changes. I have a lot more concepts, and I broke the 120 questions down into the topics that I tutor. All right, so those are the updates, and so now let's get into the video. Let's roll it.
Good morning, everyone. This is Annalise Garrison. Many of you all know by now that I've been a nurse since 1996, and I've been helping nursing students pass their NCLEX since 1997. I'm going to tell you right up front, the reason I've been helping nurses since 1997 is because I myself failed the NCLEX twice and passed it on my third try. So, and I'm not ashamed to admit that. Failure is the back door to success. It doesn't matter how many times you take the NCLEX. Ultimately, it's important that we pass. And at the time, I did not have anybody to help me with my NCLEX. This is why I've been dedicated to helping nursing students pass their NCLEX since 1997, with great success, I may add. All right? Now, the reason I'm bringing this to you today is because I've been tutoring only for about 8 to 9 months. But the interesting thing is I'm having such great success with the tutoring. And it is because of these 8 essential concepts for the NCLEX that I'm bringing to you today. Now, if you're getting tutoring from me, it's $30 an hour private and $20 an hour group. No more than 4 people in a group. All right? And the other thing I want to tell you before I get started is I don't want you to confuse the 120 questions that I share via tutoring only. So don't ask me to send these questions to you. I will not, because I have to protect my property. All right? So the 120 questions is not part of the 265 questions that you see on my website. The 265 questions is part of my Delegation and Prioritization seminar, totally separate from the 8 essential concepts of the NCLEX that I use to bring this to you. All right? Now, how long does it take me to get through all these questions people have been asking me? It takes me about 11 hours to get through the 120 questions. Because I like to get through those questions, I like to make sure you understand the concepts, and then I like to quiz you and test you and make sure that you're understanding those concepts, that you're using your time wisely for the NCLEX, and figure out any weaknesses that you may have before you take your exam. So this is the purpose of this presentation today. The NCLEX is not core nursing. I don't care what you've heard anyone say, including your instructors. All right? They mean well, but the NCLEX is much, much higher than core nursing. Core nursing, what do I mean by core nursing? I mean your basic nursing, you know? Your 9-system body review, med-surg, endocrine, OBGYN, psych. This is all core nursing. This is the stuff that you learned in school. Alright? You will hear many of your instructors say, oh, if you get a high grade on the ATI or the HESI, you're going to pass the NCLEX. With all due respect, I believe this is a fallacy. Alright? Because what do we do when the NCLEX asks us legal questions? What do we do when the NCLEX asks us questions about infection control? What do we do when the NCLEX asks us questions about prioritization? Who to delegate to? These are not core nursing. This is not core nursing. And you have to get 50% of the expert questions correct to pass your NCLEX. So this is the purpose of this presentation today. Now, any of you getting tutoring from me, you must watch this video before you get any tutoring from me at all. Now, and then after you watch this video, it will take me about 11 hours if you wish to go through all the tutoring, all the questions, to tutor you. Now, you don't have to get 11 hours, ladies and gentlemen. You can I'll just work with what you have. If you only have $100, then I'll give you 5 hours of tutoring or 3 hours of tutoring. However much, and I'll focus on what you want me to focus on. If you want me to focus on infection control and delegation and prioritization, I'll do that in 3 hours. Because that's what you gave me. You gave me 3 hours. But if you want all of my concepts, and if you want all of my questions, it'll take about 11 hours after you watch this video. Alright? Alright, so now, if we have a pen and a piece of paper, we'll get started with the first concept of today. There's 8 concepts. And we will talk about the first one here. Number 1, infection control. When you work with infection control questions, you need to understand and put your disease process in 4 categories, and that would be standard, contact, droplet, or airborne. So you need to know whether this disease process is standard, droplet, airborne, or contact. Right? If you look at TB, that's what? Airborne. If we look at impetigo, that's what? Contact. If we look at VRE, vancomycin-resistant enterococci, that's what? Contact. If we look at something like C. diff, contact. If we look at something like measles, airborne. So we need to know, you need to be able to put your disease process in these different categories. Contact, standard, droplet, airborne. Okay? For the most part, airborne will get the private room. But how do you know that if you don't know what microorganisms are airborne microorganisms? So, that's number 1. Put your disease processes in the different categories. Standard, contact, airborne, and droplet. Okay? Number 2. You can room 2 people in the same room, regardless of the disease process, as long as they have the same microorganism or the same virus. Okay? Let me repeat that. You can put 2 people in the same room as long as they have the same bacteria or the same virus. For example, you could stick a person with glomerulonephritis in the same room with a person with strep throat. Why? Because they're both caused by the same bacteria. They're both caused by the streptococcal bacteria. Okay? Let me give you a viral example. You could stick 2 people in the same room if one had shingles and if one had chickenpox. Why? Because they're caused by the same virus. This is why we can put the people in the room together. Unless there's any other extraneous variables going on. What do I mean by extraneous variables? Unless there's anything else going on, then they need a private room. Alright, let me give you an example. If we have an 84-year-old, again, we'll use the shingles and the chicken pox again, right? We have the 84-year-old with shingles, we have the 24-year-old with chicken pox. They could go in the same room, unless the 84-year-old is being treated for a decubitus ulcer, right? Or they can go in the same room, unless the 24-year-old has a UTI, right? And then they would get a private room. So, two people can room the same room as long as they have the same bacteria and the same virus, unless there's something else going on with the individual. Then they get a private room. Now, who gets the only available private room? Well, that depends on whether your question is a contact, droplet, standard disease process, or whether it's an airborne disease process. For the NCLEX, normally your airborne disease process will get the private room. But look at your question, okay? If they all deal with contact, and they have the same microorganism, but somebody's got a D-cube or somebody's got a UTI, okay, then they get a private room. Let's use this glomerulonephritis, for example. The 84-year-old with glomerulonephritis, but he has a stage 3 decubitus ulcer, then he would get the private room. Alright? So I'm hoping that you understand that concept. And it's at this point that I would give you questions. However, the questions will not be available here. What I want you to do is I want you to take notes, and then come to me with these notes, and then I will give you examples and questions to go with this type of example. Alright? Very good. Number 2, let's talk about delegation. Okay, now there's two things I want to talk about when we talk about with delegation. We want to know what you can delegate and what you cannot delegate. Whether you're an LPN delegating to another LPN or an aide, or whether you're an RN delegating to another RN, an LPN, or an aide. I go over this more thoroughly in tutoring. Remember, this is just a prerequisite for the tutoring. Just take notes, and then any questions you have, we'll go over more thoroughly in tutoring. Alright? First, I want to go over what do I want to do? Let's do what we cannot delegate, okay? You cannot delegate new admissions, or new assessments, right? Now, you're saying to yourself, well, what's a new admission versus an old admission, right? So I will discuss this more in tutoring, but let's use an example. Like, for an example, when you're working in a nursing home, for example, and your client goes out to visit his family, we will do a routine assessment before we release that client into their family. Then we will do a routine assessment when that client comes back, okay? This would be considered a routine assessment, something that reoccurs, right? But you cannot delegate new assessments or new admissions, right? And this is what we usually do in the hospital and nursing homes as well. And this mostly is concerned with the RN. The RN cannot delegate new admissions or new assessments. Now, if, for you LPNs, if the NCLEX is saying the charge nurse, blah, 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 all right, think of it as you being the charge nurse. Don't say, oh, I can't do that because I'm not the charge nurse, I'm the LPN. No, you're taking the LPN NCLEX. So, if it says the charge nurse, you are the charge nurse. The question is direct towards you. Alright? Now, they test the same thing, but they use different wording. So I know for sure for the RN, they say the charge nurse. For the LPN, they may say a different wording, but it's still, every question involves you, all right? So, answer the question as if it's directed towards you, all right? So, you cannot delegate new admissions or new assessments. You cannot delegate teaching. You cannot delegate management. Now, what do I mean by management? You can't delegate, I don't know what I mean by management. We'll discuss that with my questions. See, the problem is I don't want to get technical and bring my questions into this. I want to protect my questions. So this is why I can't give you an example of management with this video. But I can certainly give you an example of management when we do the tutoring. I know what I'm talking about with that. But I want to protect my questions here. So I'm not going to, you just know that you can't delegate management. Write that in your notes. Alright? Good job. Alright, and then you cannot delegate discharges. Alright? So there's 4 things we can't delegate. New admissions or new assessments, teaching, management, and discharges. Alright? Again, if you're an LPN and you're getting tutoring from me, I'm going to be specific to you as an LPN. If you're an RN and you're getting tutoring from me, I'm going to be specific to you as an RN. I won't go into detail here. Just write it down. Alright? Thank you very much. Now, these are things that you can delegate. Alright? Things that you can delegate, and there's 5 of them. Okay? You can delegate things that frequently occur. You can delegate things that are considered technical by nature. Alright? You can delegate things that are considered standard and unchanging. You can delegate things that have predictable results. And you can delegate things that have minimal potential for risk. Pardon me. So, let's go back here. Things that frequently occur. Give me an example of that, Garrison, you might ask me, right? Well, alright, if you're an LPN, you could certainly delegate I&Os to your aide. Alright? If you are a RN, you could certainly delegate med administration to the LPN. That's what she went to school for. He or she went to school for, right? They know how to give meds. These are things that frequently occur. Alright? Things that are considered technical by nature. What's an example of that? Well, if you're an RN, you can delegate the changing of a Foley cath, for example, to the LPN, right? She knows how to do that. If you're an LPN, you can delegate the changing of the urine bag to the CNA. All right. Now, the bag, the changing of the bag, not the cath, the changing of the bag. The CNA can change the bag. All right. That's an example. This is one example of numerous examples. And if you have a specific question, just ask me. I'll tell you in the tutoring session. Alright? Let's see, number 3. Considered standard and unchanging. Now, what do I mean by that? Let's say, if a patient with a myocardial infarction just got admitted to the hospital, okay, an hour ago, I wouldn't delegate this to the LPN because this patient is not stable yet. Okay? If you're an LPN, I would not delegate doing the vital signs, even though your aide may be qualified to take the vital signs of the patients. I would not delegate the vital signs of this myocardial infarction patient to the aide until the vital signs become stable. Okay? You can only delegate things that are stable and unchanging. Alright? I had to think there for a minute. Okay? Even I have to think. That's pretty interesting. So, so don't delegate anything about your patient to anybody until they're stable, whether you're an RN or an LPN, right? And I'll go further. I'll be more specific to you if you're an LPN or RN in the tutoring sessions. All right. You can delegate things that have predictable results. Give me an example of that, Garrison, you might say. All right, well, I will. You can certainly delegate, for example, you know how we have brittle diabetic, and you might see the doctor order written on the chart. You know, if the blood sugar is 200 to 250, give this much insulin. If the order is 250 to 300, give this much insulin. If the order is 300 to 3, if the insulin is 300 to 350, then give this much insulin. Okay, this has a predictable result. Whatever the insulin is, that's how much. Sorry, whatever the blood sugar is, that's how much insulin we're going to give. Simple as that. Predictable result. Okay? That's what I mean by a predictable result. Now, would you delegate neuro checks? No. Suppose somebody comes in with a concussion. That does not have a predictable result yet because the patient is not stable. Okay? So you can only delegate things that have predictable results. Okay? Your aide can certainly take vital signs of the patient that is stable because that patient has a predictable result that there's a 98% chance that their blood pressure will be WNL, right? Within normal limits, right? So that's what we delegate. We can delegate things that have predictable results. Okay? And then you can delegate things that have minimal potential for risk. What does that mean? Well, let me think here. Okay, for example, I, myself, would not delegate someone who has a PICC line. Okay, why not? Because that PICC line dressing change has to be completely sterile. If it is not completely sterile, what will happen? We will get an infection. And where will that infection go? Directly into the bloodstream. And when we get an infection that goes directly into the bloodstream, what is that called? Sepsis. If it's in the urine, it's urinary sepsis. So it depends on where this infection is in the body. It depends on what we call it. So, but an infection directly in the bloodstream is very dangerous. So I would not delegate this sterile dressing change. Okay? You can delegate things that have minimal potential for risk. Okay? You don't want to delegate, for example, the 64-year-old prima gravida. Why not? Because it's her first pregnancy, and she's obviously high risk because she's 64. Right? So don't delegate that. Again, I'll be more specific when I go into the tutoring session. I'm just giving you general ideas here. Alright? So I've discussed in this section about delegation what you can delegate and what you cannot delegate. Alright? And now we will discuss prioritization will be next. So when it comes to prioritization, there's two concepts under prioritization that I want you to know. This is an extremely important category because this will help you choose the right answer on which patient would you see first, or which patient would you assess first, or who needs immediate attention. This concept on prioritization will help you immensely with these kinds of questions. And the first subcategory under prioritization is acute versus chronic, and the second category is never pick the symptom of the disease. Alright, so let's talk about the first one, acute versus chronic. When the NCLEX throws out one disease process out at you, whether it's ulcerative colitis, diabetes, myocardial infarction, whatever it may be, if the answers all have to do with that particular topic, then you want to pick the acute symptom over the chronic symptom. What do I mean by that? Well, let's take diabetes for example. Okay? Chronic symptom of diabetics is what? What I mean by chronic is something that you live with on a day-to-day basis that is controlled by medication, or something that you see the doctor for on a constant basis that's controlled under a physician's care. Taking the diabetic for an example, the diabetic may wear glasses, right? Because he's got poor eyesight because of his poor sugar control. Alright, so he goes to the eye doctor for that. Fine, not a problem. The diabetic may have a 40% heart blockage because of his poor sugar control. That's okay. Chronic. He goes to the cardiologist. The cardiologist gives him heart medication. The diabetic may have poor kidney output. He goes to the nephrologist. The nephrologist gives him medication for his kidneys. You see what I mean? These are all chronic symptoms. Chronic symptoms is something that a person lives with on a day-to-day basis that's controlled by medication or some type of, keeping track of it in some way. Alright? Now, suppose this diabetic was all of a sudden cold and clammy or was unconscious. Okay, this is not normal for the diabetic. This would be an acute symptom. So we would pick this. This is one small example of acute versus chronic. When the NCLEX throws out one disease process and all the answers have to do with that one particular disease process, you want to pick the acute symptom over the chronic symptom. This is what you would assess first. That makes sense. But now, the problem arises when the NCLEX throws out 4 disease processes at you. How do you know who to pick first? Who to see first? Who to assess first? What needs immediate intervention? Well, let me tell you something, ladies and gentlemen. The NCLEX is so over airway, breathing, and circulation. Don't go by airway, breathing, and circulation. We're so done with it. The NCLEX is not that simple. Alright? This is what I want you to remember. When the NCLEX throws out 4 disease processes at you, you never want to pick the symptom of the disease. Alright? What do I mean by that? Let me give you some examples. Alright? Your client has diabetes type 1, numbness and tingling in the legs. Okay, not comfortable, but don't pick it. Because numbness and tingling in the legs, neuropathy, is normal for diabetics. And this is why they go to the foot doctor, the podiatrist, right? Or the neurologist, whichever one they go to. This is a normal symptom for a diabetic. Not a pleasant one, not a good one, but a normal one. Never pick the symptom of the disease. This is normal for the diabetic. Alright? COPD with pursed lip breathing. Many of the students go, oh my God, airway breathing circulation, pick it. No, don't pick it. COPD with pursed lip breathing. Pursed lip breathing is normal for a COPDer. Okay? So don't pick COPD just because, airway. No. Alright? Let me see. Primary hypertension of a blood pressure of 160/90. Oh my God, airway breathing circulation, pick it. No, don't pick it. Because 160/90 is primary hypertension. Don't pick it. Alright. Lung cancer with a blood pressure of 90/60. Is this blood pressure normal for a lung cancer patient? No. Therefore, you pick it. Because low hypotension is not normal for lung cancer. So you see what I'm trying to say here? Never pick the symptom of the disease when the NCLEX throws out 4 disease processes at you. Never pick the symptom of the disease. So, you see why I'm saying that the NCLEX is so over airway breathing circulation? It's not that easy. I want you to remember what? Never pick the symptom of the disease. Now, it might be an unpleasant symptom, but I don't want you to pick it if that symptom is normal for that disease process. Pursed lip breathing, COPD, normal. Numbness and tingling in the legs, diabetic type 1, normal. 160/90, primary hypertension, normal. Blood pressure of 90/60, lung cancer, not normal. Pick it. So, that's what I want you to remember. 2 subcategories under prioritization. Pick the acute symptom over the chronic when the NCLEX throws out 1 disease process out at you, as in my example that I used with the diabetic. And then when the NCLEX throws 4 disease processes out at you, pick the unusual symptom. Pick the symptom that does not go with that disease process. If you can get these 2 concepts down, you will know who to pick first, who to assess first, what needs immediate attention every time. Alright? So that's a very important concept and extremely important for the NCLEX. It doesn't matter whether you're an LPN, RN, this concept works the same way. So that's my 3rd concept. Let's talk about okay, the 4th concept I want to talk about is pain. For the NCLEX, pain is usually not the answer. However, every once in a while it is. So how do we know when to pick pain as the correct answer on the NCLEX? When it comes to pain, we have to remember 2 things. 1, pain is a psychosocial need that always comes after physiological needs. So, if there's no physiological needs in the answer, and you can narrow it down to 2 pain answers, the second criteria you have to remember about pain is that you want to pick the pain answer that is more precise. Now, if I was tutoring you, it would be at this point that I would give you an example. But I want to protect my property and my questions here, so I'm going to verbally give you an example. Again, assuming that there's no physiological needs in the answer, we want to pick the pain answer that's more precise. Here we go. Patient has a thyroidectomy, 1 hour ago and is reporting anterior neck pain, as opposed to maybe an answer that goes something like this. Has a headache, level 7 on a scale of 1 to 10. Okay, that level 7 is pretty high on a scale of 1 to 10. So you would want to pick the headache answer. See how it's more precise than anterior neck pain? Alright? But remember that your pain has to fit 2 criteria. It's always a psychosocial need that comes after physiological needs. And then, if it meets that criteria, then you want to pick the more precise pain answer. Now, you need to be careful. Well, before I say this, let me just go back a little bit. So whenever you see a level and a scale, pick that. That will be the answer. Whenever it has anything to do with pain and you see a level and a scale, pick the pain answer. However, you need to be careful, all right, when you're dealing with this type of question. Let me give you an example of a correct pain answer. All right. Let's take ulcerative colitis as the physiological need as an example, and then we'll use pain again. All right. Okay. Patient has ulcerative colitis with bloody diarrhea, or headache level 7 on a scale of 1 to 10. Alright, the ulcerative colitis with the bloody diarrhea is a physiological need. However, there's nothing wrong with that answer, because remember what I said? Never pick the symptom of the disease. So, ulcerative colitis with bloody diarrhea. This is correct. This is a symptom of the disease. Therefore, we would go with the pain answer, the headache, level 7 on a scale of 1 to 10. Okay? But every once in a while, the NCLEX will throw in a pain answer with a level and a scale, and just because I go over these concepts with people, people pick that pain answer when there's a physiological need in the question as an answer, so therefore pain was the wrong answer. Let me give you an example of this one where you would pick pain, it would be the wrong answer. Let's use ulcerative colitis again. Alright? Client has ulcerative colitis, 4 bouts of bloody diarrhea in 6 hours. Alright? And then we have headache, level 7 on a scale of 1 to 10. Now, after I go over the concept, people would say, level scale, pick it. No, you don't want to pick it in this case, because there's a physiological need that needs to be met and seen first. Ulcerative colitis with 4 bouts of bloody diarrhea in 6 hours is not normal for ulcerative colitis, right? Ulcerative colitis with blood-tinged diarrhea is normal, but not 4 episodes of bloody diarrhea in 6 hours. So in this case, there's a physiological need that needs to be met. So therefore, we don't automatically pick the pain just because it has a level and a scale. Now, it's at this point that I would give you questions. Again, I'm not going to put the questions here because I need to protect my questions and my information about the NCLEX. But I will certainly go over this concept with you when I'm tutoring you, and this is a very important concept to understand when it comes to pain. So pain always has to fit 2 criteria. It's always a psychosocial need that always comes after physiological needs, and when you can narrow it down to 2 pain answers, you want to pick the pain answer that is more precise, and that usually has to do with a level and a scale, whether it's an incisional pain whether it's a headache, whatever the pain may be. If you see a level and a scale, think about picking it, because it just may be the right choice for the NCLEX. So that's pain. That's the concept of pain. Now let's go to our next concept. Now for our fifth concept, we're going to talk about how to triage in a disaster. I did this seminar a couple years ago, quite a number of years ago now, since 9/11 and like the bombings in Boston, unfortunately, the Minnesota bridge collapsing and stuff like this. So I wanted to explain the difference between how do you triage in a disaster at the scene as opposed to at the hospital. So I did a seminar on this, and there are some questions about this on the NCLEX. So I'm going to put a slide up here about triage. I want you to take the word triage and write this: T for trauma, R for respiratory, I for intracranial pressure or mental status, A for an infection, G for GI wounds, and E for extremities. Now you notice on the slide it has internal forward, external backwards. What I mean by external, I mean at the scene. So on the NCLEX it'll say the nurse is participating in an external disaster. This means that you're participating in a disaster at the scene of the accident. So at the scene, you want to take the acronym that I just gave you, triage. You want to take that acronym and work backwards. In other words, you want to help at the scene, you want to help the least injured first. Once they're at the hospital, you want to help the most injured first. Okay? The most critically injured first. At the scene, you help the least injured first. The reason being is at the scene of an accident or at the scene of a disaster, you want to help the most amount of people in the least amount of time. Now, when you're at the hospital, of course, you take the most critical person first. And we do this by remembering the acronym triage. Okay? Triage at the scene, acronym triage backwards. So we want to help the person with the broken leg, for example, first. E for extremities, as opposed to the low blood pressure, no pulse patient. That's the most traumatized patient first. You understand? So at the scene, triage backwards, that acronym, triage backwards. At the hospital, triage forwards. Alright? Now, at the scene, we do no CPR. We do not have a pen light. We do not have a stethoscope. We don't do any of this. The only thing we do is check for breathing and a pulse. The only thing you can do at the scene is manipulate the head, for example. If they're unconscious, manipulate their head. Check for a pulse, check for breathing, manipulate their head. If they're breathing, that's fine. Then you move on to the next one. But you only have 60 seconds per person to make this decision. Now on the NCLEX, to maybe help you understand what they're talking about, they might say unresponsive, lacerations to the head, blood pressure of 50/40. But in the real world, we don't use any blood pressure cuffs, so we don't know that the blood pressure is really 50/40. But you'll see it this way on the NCLEX, okay? You just got to remember, at the scene, you help the most amount of people in the least amount of time. The reason we don't do CPR is because we're taking two people to help one person when we could have two people save 20 people, alright? So you want to help the least injured first. So you have your safe area, that's your green area. All the people that can get up and walk, they can walk to that safe area, all right? You can't assume that 50 fire trucks, 100 EMTs, and the whole police force is going to show up. You have to assume that you're going to be the only nurse at the scene. So what are you going to do as the only nurse at the scene? So you want to help all the people that can move first, put them over to your green area. Alright? You want to help the person with the broken leg first, because they can move. Okay? Then you want to help any GI wounds. Sometimes people get impaled in the abdomen. If that happens, by the way, if anybody gets impaled, okay, you want to leave the object in the abdomen or wherever it is and try to stabilize that object as much as possible. Okay? I'll give you a story. My neighbor, for example, my neighbor and his girlfriend were, roughhousing, running around the house, and my neighbor's girlfriend ran into the room and slammed the door shut. Well, on the back of the door, there was a coat hook, all right? And that coat hook hit the gentleman in the eye, and his eye was hanging by its tendon out of its socket. Okay, so I came over there. They asked me to help. So I came over there, and the only thing I could do was take a styrofoam cup, cut it in half, and tape it onto his eye. I didn't touch his eye at all, right? I just put that styrofoam cup over his eyeball, over his eye, so that the eyeball would stay there and not break away from the tendon. And, in the end, he went to Wills Eye Hospital and he was fine. These are some of the things that you may have to improvise when you're at the scene of an accident. So whenever anything is impaled, leave it there, but try to stabilize it. Now don't forget you have your whole green area. So like if you need to make a makeshift tourniquet to rip some guy's shirt to stop the bleeding, by all means do that. Ask someone from your green area if you could borrow their shirt, right? You have a good area, you have a little resource, right? The green area. Don't forget to use the people if they're willing to help you, and use whatever they have that can be of help to you. Alright? So we move the broken leg out of the way first, then we do the GIs, the gastrointestinal wounds, and then we do the an infection. Like I said, keep that whatever's impaled, keep it there and just stabilize it to prevent infection. Alright? And then you want to go, what's next? Intracranial pressure, maybe the laceration to the forehead that's confused, you would help him next. You see how we're taking triage and going backwards? And then we help the respiratory person next. And then we help the person that is unconscious, no pulse. This person probably will get a black tag, but we help that person last. Now, all the other people will get red or yellow tags. This doesn't mean that we're going to keep the black tag person there and say, oh, to heck with them, just let them die. But when help does arrive, we're going to take these people in order. So the red tag people will go first, and then the yellow tags, and then the black tags will be last. Okay? And once we're at the hospital, we want to take the acronym triage and move forward. Take the most traumatized person first. So that unconscious person that had no pulse, well, wasn't breathing but had a pulse, we would take him first to see if we could rescue him or her, right? And then we would take the respiratory, then we would take the laceration to the forehead, right? The unable to follow simple commands, intracranial pressure, mental status, we would take him third. Then we would take the impaled person, maybe the person that has the stick in his abdomen, whatever, right? We would take him next. Then we would take the GI wound next, and then of course we would take the extremity last. The extremity, the broken leg, can wait. So this is the concept behind triaging for the NCLEX. At the scene, they're going to call it an external disaster. So The nurse is participating in an external disaster, so we help the least injured first. Take the acronym Triage, EGAIRT. Go backwards at the scene. Once you're at the hospital, take the acronym Triage, TRIAGE, and move forwards with it. And it's just that simple. If you can understand that concept, you'll get those kinds of questions right on the NCLEX each and every time. And this is one of my favorite subjects. I taught the seminar, and I was happy to hear that it was on the NCLEX. So there you go. That's the concept for triage and the NCLEX. Remember that, and you'll get the question right every time. Okay. All right, let's go to the next concept. Sixth concept I want to talk about is dealing with the doctor. I will call my primary care physician if. These are the types of questions I'm going to discuss, okay? First of all, most of the time, calling the physician is not the answer. So please take all the concepts that I've showed you and told you about and gone over with you when we tutored with our time together, and do not call the doctor unless one or all three of these things occur. You call the physician when, number one, there's unexplained weight loss or gain. Number two, you have to clarify an order. Or number three, when you see severe side effects of a medication or signs of toxicity. No matter what that question says and what those answers are, never call the physician unless one of these three things occur. Unless you choose one of these three things, your answer will always be wrong for the NCLEX. And that's my concept number 6. Just that simple. Only call the physician when there's a lot of weight loss or a lot of weight gain. You need to clarify an order, or you see signs or severe side effects of a medication or signs of toxicity. That's it. Only these 3 times. Because the NCLEX wants to test your ability to practice nursing safely. Anybody can call somebody else and say, what should I do? But the NCLEX wants to see if you can practice nursing safely, if you can be the team leader. So these are the only 3 times you call the physician. Next concept. Okay, I have 2 more concepts I'd like to go over before I go to bed for the evening. It's been a long day, so I'm not pretentious. I don't mind that I'm in my pajamas, and I hope you don't mind either. Because the important thing is the content of this video. So up to this point we've talked about 6 concepts. The 7th concept I want to talk about is therapeutic communication. And under therapeutic communication there's 6 subcategories. And that would be, don't ask why questions. Okay? Don't ask why questions. Don't patronize. I'll give you an example of each of these. You want to mirror or paraphrase what the client says to you and say it back to them. You want to assess the need of the caregiver. You want to include your client and your caregiver whenever possible. And number 6, you don't want to be judgmental. You want to be neutral. You want to keep yourself out of the conversation as far as stating your opinion, maybe perhaps your religion, your belief, your judgment. You stay a neutral third party. Those are the 6 subcategories under therapeutic communication. Now let me give you an example of all of them in case you missed some of them, okay? For example, the client states, I don't want to go out in public anymore. I have to use a walker and everyone stares at me. You respond, are you thinking about not going out anymore? Okay, in this example, what did we do? We basically paraphrased or mirrored what the client said to keep the conversation open-ended, correct? So this is what you want to remember for the NCLEX. Paraphrase or mirror what the client says to you to keep the conversation open-ended. There's more therapeutic communication on the NCLEX than you realize. So this is why it's important to go over this concept. Alright? Here's another example. A 77-year-old client just had a hip replacement and states, I'm not recovering quick enough. I wish I could do better. You respond, I have helped a lot of people in your same situation. You're doing just fine. So of the 6 subcategories that I mentioned under therapeutic communication, what is this doing? This is patronizing the client. You do not want to patronize your client. The client doesn't care how someone else is doing. They only care about their well-being. They're the one that wants to get well. They want to do better. So do not patronize your client by comparing them to someone else. Okay? Third, you observed the spouse of a cancer client sitting in a slumped over posture, and you state, tell me, what has your family done to help you? Okay, this would be a correct response for the NCLEX, because what are we doing when we say, tell me, what has your family done to help you? We are assessing the need of our caregiver. When we ask what the family has done to help us, we're assessing this caregiver's support system. Does he have family to help him? Does he have friends to help him? And if not, maybe we want to involve perhaps his church. Maybe we can get some home health care in his home for a couple hours a week to give him some help, him or her some help with his loved one, right? Maybe they need to have a respite. They need to put their loved one in a nursing home for a little bit so that they can go on vacation. So this is not judgmental. Tell me what your family has done to help you is assessing the need of your caregiver by assessing his support group, his or her support group, right? So this is what we're doing. We're assessing the need of the caregiver when we say something like this, right? A client is suffering from severe depression and refuses any communication with you. You state, I know this is a very difficult time for you. Can you please explain why you feel this way? We are all here to help you. You're going to be okay now. Not only is this response patronizing, but it's got the 3 little words in there that we should never ask. Can you please explain why you feel this way? Do not ask why questions. If your client knew why, they wouldn't be here, right? What's going to happen if you ask a why question and your client goes, I don't know? That's the end of the conversation, right? So do not ask why questions. Okay? A caregiver of an Alzheimer's client states, I know I should not be angry, but I just cannot help it. When a caregiver expresses their feelings like this, whether they're depressed, angry, upset, you as a nurse need to take further steps. you want to assess why he's angry. Okay? If you leave an angry caregiver to take care of the Alzheimer's patient, what's going to happen to the Alzheimer's patient? They're eventually going to be abused or neglected, correct? So if we don't intervene, perhaps more teaching about the actual disease, about Alzheimer's, right? Perhaps a support group. We need to intervene on this caregiver's behalf, because if we don't, then the client is going to eventually be neglected or abused, and we don't want that to happen. Okay? And the last example is, remember I said always include the caregiver and the client whenever possible? Listen to this one. A 2-year-old is crying in the waiting room. The mother is demanding that the child should stop crying. You respond, let's see how your toddler responds when you talk in a softer tone of voice. This is correct for the NCLEX. In other words, you're including the caregiver and the client whenever possible. And you did this. You said to the mother, let us see. That included the mother, who in this case was the caregiver, and the toddler, who in this case was your client. So, all these things are important to know for the NCLEX when it comes to therapeutic communication. So just to summarize, you don't want to ask why questions. Okay? You want to mirror or paraphrase what the client says to you to keep the conversation open-ended. Third, you want to assess the need of the client and the caregiver whenever possible. Fourth, you want to assess the need of the caregiver. You want to intervene on the caregiver's behalf if necessary. Right? Fifth, you don't want to patronize. And sixth, you want to remain totally neutral and non-judgmental, non-opinionated. Don't bring your beliefs into it. Okay? These are the 6 subcategories that you need to know when it comes to therapeutic communication for the NCLEX. Alright? That's very good that we understand that concept. It's going to become very important when you take your NCLEX. Okay, let's move on to the next category, shall we? Okay, well, great. This brings us to my last concept of these 8 concepts, and this would be, I'm going to label it multidisciplinary teamwork. Okay? For the RN exam, you're actually going to see the word multidisciplinary team, right? For the LPN, this might take the form of social worker, OT, PT, psychiatrist, dietitian, whatever the case may be. But when you see these types of people, you want to think multidisciplinary teamwork. Okay? Now, there's 3 things you want to remember when approaching this concept, and that is communication, collaboration, and shared responsibility, of which communication is always first. Okay? And don't forget that collaboration. Alright? You want to make sure you collaborate. It's a shared responsibility. This is not the time to be delegating. Okay? This is not the time to be referring someone to a cardiologist, for example. Multidisciplinary teamwork is collaboration. Alright? Remember that. You as a nurse want to stay within the scope of your practice. What is this? Why am I even bringing this up? Because you did not go to school to be an occupational therapist, a speech therapist, a dietitian, right? So you have no scope to say who's doing their job right and who's doing their job incorrectly. Now, for example, suppose Joe shows up an hour late for his respiratory therapy, or suppose he's using the wrong mask, alright? We have to stay within the scope of our practice, but does this mean that we just let Joe do what he wants to do because we didn't go to school to be a respiratory therapist? Absolutely not. It would be out of our scope of practice to replace Joe. It would be out of our scope of practice to correct Joe. It would be out of our scope of practice to tell Joe what he's doing right and what he's doing wrong. But it would not be out of our scope of practice to talk one leader to another leader, right? One supervisor to another supervisor, and call Joe's supervisor and talk with his supervisor and express your concerns, supervisor to supervisor, team leader to team leader, representative to representative, what problems, thoughts, concerns, or praise even you may be having with Joe, so that the correct person can correct Joe. If you corrected Joe, or if you praised Joe, if you wanted Joe to get a raise or something like this, this would be out of your scope of practice, right? But you can communicate team leader to team leader. That's the important thing. This is what I want you to remember. Now, it would be at this point that I would give you a lot of some questions on this topic for the NCLEX. Again, I can't do it here because I have to protect my questions here. So this is why we need to get some tutoring so that I can go over these concepts with you and show you with questions this concept. Alright? Another important thing is you don't necessarily want to pick the most dire patient. Alright? But you want to pick the patient who needs the most team members. Okay? For example, we have a patient who came in with into the ER with a heart attack, and then we have a patient who was admitted 2 days ago with a C4 spinal injury. Okay? On the surface, the heart attack patient is the more critical patient, correct? But when we're dealing with multidisciplinary teamwork, we don't want to pick the most critical patient. We want to pick the client who needs the most members of the whole team. And in this case, with the two examples I gave you, it would be the C4 spinal cord injury. Why? Because he or she is going to need occupational therapy, speech therapy, nurses, doctors, maybe home health, maybe a CNA. We're going to need a carpenter to go out to his house to assess whether he has stairs. Does he need a ramp now or not? Go into his house. Where's his bedroom? Was his bedroom upstairs? It's going to have to come downstairs. So, in this example, you see how the C4 spinal cord injury needs more people than the heart attack patient. The heart attack patient is more critical, yes, but who does he or she need? Just the medical team, and it stops there, right? So in my questions, we would go over these questions and we would practice this concept, because this is one of the more difficult concepts, I would say. But it's relatively easy if we practice this together with questions during a tutoring session. Alright? So, when you see the word multidisciplinary, RNs, okay? LPNs, when you see social worker, when you see occupational therapist, dietitian, whatever, don't think most critical patient. Think, I keep saying patient, I mean to say client. The NCLEX never says patient anymore. It says client, okay? So when you see these words, you want to think, okay, which one of these clients in the answer needs the most members of the whole multidisciplinary team. You want to involve as many people as possible in the well-being of that client. Alright? That's what the concept of multidisciplinary is all about. Communication, collaboration, and shared responsibility. Without going out of your scope of practice. You have to stay in your scope of practice, and you don't necessarily want to pick the most critical client, but the client that needs the most members of the whole team. Alright? So that's all 8 of my concepts. And it is my hope that if you found this helpful, that you decide to get some tutoring with me. Again, I just want to close by saying, don't confuse the 265 delegation and prioritization questions with the 120 questions I have to demonstrate these concepts for the NCLEX. Alright? And with that, I'll say goodnight, and I want to wish every single one of you good luck on your NCLEX. And be blessed in your endeavors, because I know we're all working very hard to pass our NCLEX. I know how you feel. Alright. Good night.